I'd like to welcome the local custodians of land in which we meet this evening and honour elders past, present and emerging. Welcome tonight to Acute Behavioural Disturbance in Children webinar. I'd like to thank you all for attending this evening. My name is Melissa Wilkinson. I'm from the education team at the Hunter New England Central Coast Primary Health Network. Bit of housekeeping for us. There will be a poll as per usual at the end of the session. I strongly encourage you to complete that so that we can gain some feedback. That feedback is really valuable to us for further education events. Also, we are being recorded this evening. You will be able to watch this on our website in the Education Library as well for further reference. If you've got any questions, I encourage you to use the chat box. We will leave some time at the end of this session to address those questions, and any that we don't get to, we will endeavour to answer via email if you want to send those into education@hccphn.com.au. I'd like to welcome this evening. We have with us Dr. Mina Rattan. She's a staff specialist paediatrician at Weill Hospital. And we've also got Olivia Gregg from Central Coast Local Health District. Thanks, Olivia, for being with us. The GP liaison and nurse consultant, and Erica Drew from Central Coast Health Pathways, the Primary Health Network. Hi, Erica. And Dr. Jill Sass, a GP from Point Clear Medical Practice. So welcome, everybody. I'm going to hand you over now to Dr. Mina Rattan and welcome you to the session. Thanks, Dr. Rattan.
Thanks, Melissa. Very good evening to all of you. So today I'm going to present on acute behavioral disturbance in children. I think this topic is very familiar to our primary care providers, and you all see children with behavioral disturbance in some capacity at different age groups. So this presentation is basically to give you an idea about behavioral disturbance in children, especially focused being on disabled children who have some sort of neurocognitive disabilities. At the same time, we will also be considering some part how these patients are managed in our emergency departments. And then I will pass over on to Olivia and Erica to talk more about resources which are available in community for you guys to access services regarding these patients. Okay, so I will just give you a little bit of an idea with two cases which are very much similar, and we often see them in our emergency departments. And these are actual cases which you guys have referred to us and have presented to our ED. So the first case is about NP, who is a 10-year-old boy. He again presented with acute behavioral disturbance and situational crisis after an argument at his place and presented to Vyong ED under Section 22. So I think the Section 22 means that he was brought in by the police. His background was that he had a usual diagnosis which these patients often have of ADHD, ODD, anxiety, had some learning difficulties at school, dyslexia, dysgraphia. He was facing some prolonged grief after a few deaths in the family members, mainly his brother, grandmother, and cousin who he was close to. There was a change in the school for him recently, and his older sister came to stay at his house with the 4 young kids, and some of his cousins had moved on in his room. He also had background of asthma, and there was additional psychosocial stresses of a single mother managing this child. He was linked with a psychologist and school counselor, used to take regular medications for his asthma, which was Seretide. The progress was that because of his behavioral disturbance, he had to be admitted to Gosford for around 3 days. He was assessed by mental health teams while he was an inpatient, so which again is a usual practice once they get admitted, and was found to have no mental health disorder and was diagnosed just with emotional dysregulation. He was discharged on risperidone, which I think you all are familiar. Risperidone is an antipsychotic drug which is used for challenging behaviors and is PBS approved to be used for autism spectrum disorder. Now he had a GP, and he was being followed up at pediatric assessment unit Vyong as well. And it was suggested that whether he should have some sort of follow-up with mental health services. But as you know, he was only 10 years old, and for a very, very long time, there were quite a scarcity of services for under 12 children which is now going to change with under 12 team become functional recently. He was also advised the facets follow-up, which is the public health psychology support, which is available to these clients, apart from appropriate school support and psychology input. It was also advised to have some sort of assessments on ongoing basis. A very similar case, another 10-year-old boy, AD, also was in similar situation. So the next case I will describe and then we will move on to the discussion. He also presented to Vyong ED with acute behavioral disturbance and situational crisis, leading on to safety issues at his place following an argument with his parents. So very similar situation. He had ongoing challenging behaviors, suspected autism, but wasn't confirmed at that stage. ADHD, anxiety disorder, not otherwise specified, had some sensory and sleep disorders, and family history of ADHD and ODD. Apart from that, there were some psychosocial stressors of previous exposure to domestic violence and few other stressors of mental health illnesses in both parents. His usual medications, again, catapres, which is a commonly used drug for sleep disturbances. He was taking some antipsychotic drugs like Seroquel 50 milligram in the morning and 150 milligram at night. Vyvanse for his ADHD. Seroquel is a drug which is again an antipsychotic, but in different doses it is used to control the anxiety as well. He was also on a mood stabilizer, Tegretol 100 milligram once a day. This patient was very upset when he arrived in ED. He had to be restrained and received IM midazolam about 2.5 milligram. ED also gave him two wafers of 2.5 milligram of olanzapine, which is again another antipsychotic drug used for challenging behaviors. And he received midazolam intramuscular 2.5 milligram. He waited in emergency department for long hours, which was almost 16 hours waiting for a bed, and had a social worker review, fax involvement, and pediatrician review as well. He was discharged home next day after risk assessment and was booked for scanned medical and medical follow-up at PAU. This was followed by medical review, and we advised him further assessments to confirm the diagnosis of autism and encourage the family to link with allied health interventions, which will include occupational therapy, speech therapy, and appropriate psychological input. Since it was a result of a argument in the family, it was also suggested to the parents to have some sort of parental training programs which will upskill them to manage the behaviors of the child. Apart from having behavioral management plan, both in the school or in home situation. So these are the two different type of cases which I think you as GPs can also encounter in your rooms. And with that kind of history, once they become acutely distressed, then they are brought in the hospital, and they remain in emergency and require different type of treatments. Now, I selected these two cases because both had some sort of underlying neurocognitive um, issues, which included ADHD, ODD, and autism spectrum disorders. So these patients may come to your clinics when they are not even diagnosed, but ongoing basis also, even after diagnosis, acute behavioral disturbance can occur at any time. So just moving forward, I will give you a little bit of an idea what actually goes on for children who have neurocognitive disabilities. So the general principles is that if a patient actually comes to our clinic or we see them in emergency department, what are the general principles we follow? Just like there is an ABCC for resuscitation, for behavioral disturbance also we follow the pattern of ABC. So A means what was the antecedent? So what happened just before the behavior of concern? And that will usually highlight what actually triggered the behavior of concern, followed by what behavior the patient displayed after that. So, for example, which could include like spitting, hitting, calling names, becoming verbally abusive, throwing things, kicking, or biting. So that can be the behavior. And C is the consequence. What happened? How did the parents respond? Did they raise their voice? Did they use any kind of force? Did they try to restrain them? Did they call for help? So that is the consequence. And what was the result of that? So that's how we ask and gather information even before going too much into background. Now, in terms of the emergency presentation, because there is a lot of confusion about whether these patients belong to mental health, whether they belong to pediatrics, but that needs to be really carefully defined, because not every patient who has got behavioral disturbance has a mental health problem. That was actually um, quite evident in case number one, if you remember, because he had a proper mental health assessment and it was found that he just has emotional dysregulation. He doesn't suffer from any mental illness. And that is the confusion which is there in multiple places. And, even emergency physicians, pediatricians, GPs, they find it really challenging to label whether this patient has a mental health problem or not. Now, so the general principles when the patient actually has behavioral disturbance also reflect ABCC, in which we see that the patient will go through these four stages of arousal and ultimately will have well established agitation. So, so the ABCC actually stands for arousal, behavior, containment, and cognitive processes. So when the agitation or aggression starts, it will always start with arousal. Arousal means patient is getting upset, he's just showing flushing of the face, and he's just getting angry, his facial expressions are changing. So that is the arousal stage, which means that he is becoming upset or angry due to a particular reason. Next thing will reflect in his behavior. So behavior means he will start pacing, he will show you the fist, he will show the rude finger, or start showing in his behavior, and start throwing things, kicking, pushing, spitting. It could appear in any form of behavior. So that means that the agitation has now started, and if at that stage it is not controlled, um, it will actually become worse, and the patient can start becoming more and more aggressive. He can abscond, he can display risk taking behaviors for himself, and could be also at risk of harming other members in the family, because at that stage his cognitive processes are already impacted, which means that he can't think rationally. Things don't make sense to him. Even parents are trying to explain him something, but he's beyond that. So it is very important to recognize agitation or aggression quite in early stage, because that is exactly what we do in hospital. If we get a patient in earlier stages of agitation, that is around A and B, they are relatively easier to manage. But once they have reached up to the stage of containment and cognitive processes, which our case 2 did reach, then they had to be restrained. They had to be given intramuscular kind of injections. They had to be sedated. And and that is a very traumatizing experience, not only for the our clients, but also to the families who are witnessing that in emergency departments. But unfortunately, those things need to happen to ensure the child's safety and also the safety of others in the hospital. Now, this is a slide which actually reflects clearly what are the reasons why these patients who have neurocognitive disabilities, especially autism, uh, they display aggression. It is just like the tip of iceberg which we see in our rooms, which we see in your GP practices, which you guys encounter, which parents tell you about the history. They tell you everything about the specific behaviors, and that's exactly what they sometimes display in emergency as well. So which could be just pushing, spitting, shouting, swearing, throwing things, and hitting. But nobody is actually able to understand the underlying deficits, which means that they often are unaware of the social rules. They are unaware of other people's feelings. They are oversensitive to noise. They get easily frustrated because their communication skills are not appropriate. They show inappropriate reactions to others. So these are the kind of hidden deficits which are really important to recognize, because then only we will be able to manage these patients more effectively. Now, whenever the patient actually has behavioral disturbance, we can't stop being doctors. So we have to follow this head to toe approach, just like any other pediatric medical patients. We also have to think of common things much more earlier rather than thinking really complex or rare diagnosis. So the common things could be that the patient is having urinary tract infection, pneumonia, otitis media, or maybe appendicitis or dental problems and fractures. But unfortunately, because if they are non-verbal or if they have limited communication skills, these are making them agitated, and that's reflecting in their behavior. It's very important again to recognize less common but more serious conditions, like it could be head injury, it could be non-accidental injury. They may have had a seizure and they are in post-ictal phase. That's the reason of their agitation. Encephalitis, delirium, electrolyte imbalance, or any hypoxia. Now, we also need to remember, as the patients grow older and we come across young people in our practices, they may be having some recreational drug use, or they may have polypharmacy started by their pediatricians or psychiatrists, which include psychostimulants, SSRIs, and on top they have taken some sort of recreational drugs or even alcohol, which can actually explain the acute disturbance in their behavior. So as both our patients were on multiple medications, so it's very difficult for us to see what exactly is underlying cause. Have they taken something, or have the parents given them something? So those kind of child protection things should also go in our background. And very rarely the mental health conditions actually are there. There is a lot of overlap for anxiety. So anxiety is no longer only mental health problem. It is becoming very common in our clients. It could be a PTSD as well, post traumatic stress disorder from psychosocial stressor, and as was evident in both of our cases, they come from very vulnerable families. um, it could be a representation of depression, because depression doesn't only mean withdrawal. In children, they may in fact become very agitated, or it could be just dysexecutive syndromes. The less common but more serious mental health disorders are fortunately very rare in children. So you will rarely come across a child or a young person with bipolar or schizophrenia, though it is not impossible. And of course, that will require expertise to make those kind of calls about those decisions, especially in consultation with the psychiatrist. Now, the other very common conditions which could explain their behavior could be developmental crisis. If once they are going through puberty, as you know, in boys, the puberty starts after 10 years of age and goes on till 18, 19 years of age. So it could be just the changes happening in their body, the hormonal changes which they can't adjust like normal children. It could be situational crisis. For example, somebody has snatched their tablet or online game. They had a fight with a peer or a sibling. They can't control their impulses because of the long exposure to screens, which is again becoming a big problem in the community. Or it could be just a psychosocial adjustment issue. For example, the patient has just changed his school, so a big change has happened, or a placement of the child has been changed. For example, if you remember in case one, there was some grief, death of some family members had happened, um, and also the sister had come to stay and his room was occupied by his cousin. So all these things are big changes for a child with the neurodevelopmental disabilities, and for them it can trigger those behaviors of concern. So when we get these patients from your rooms or from our clinics to emergency department, we need to remember that it is really important to recognize them early. In our emergency departments, often there is a lot of waiting time. So proactive management of these children and early recognition of their distress is really important, because if their distress is not recognized and nothing is done to relieve it, then only they become dangerous, because the disease is overlying always there. So they are doing this because they have some underlying disorder, but it's not important at that stage when they are getting upset or they are getting more and more agitated and their behavior is becoming worse. So the first thing we need to focus is to control the distress so that they don't become dangerous and don't require physical restraint, chemical medications, parenteral medications, which can be more traumatizing and distressing both for the child and the family. Now, when these clients come to emergencies, the challenging additional challenges for them is that it is a strange, noisy, unfamiliar environment, and they feel threatened to be separated from their parents. They are concerned that they may have some needles. Triage can be an inappropriate, which is because of the long waiting times. If nurses are trying to just check their blood pressure, they may consider it as a threat. Staff appreciation of patients' level of functioning and a unique way of communicating also vary greatly, because not everybody would have experience of dealing with patients who have autism, for example, because it's really important to use their carers more effectively, to use the visual aids, for example, but that's not always possible because we have varying staff. How should it be approached? The approach should always be multidisciplinary and teamwork approach, which may include in emergency department, emergency physicians, psychiatrists, allied health, social workers, or carers. It's really important. I can't emphasize more. We have to recognize the distress early so that we can appropriately escalate and provide some relief of that distress before it is out of control. It is really important to follow the local guidelines and the policies. In terms of medications, we generally avoid oral benzos because that can cause disinhibition in autistic children. So it is just causing them sedation and they may get disinhibited. So we try to avoid benzos. And if you remember the cases, we used olanzapine. So that is for distress relief, or risperidone for distress relief in these situations. Um, and in fact, emergency or first interaction with the patient is not an indication to start any drugs. It is really important that they should be settled and these drugs are considered in the community after consideration all the family dynamics and different other factors which may be actually triggering those behaviors of concerns. We need to continue doing proactive crisis management once they are out of emergency department as well. We need to use the parent and their carers very effectively because they know them well, they know their habits well, they know what their child likes, they know which toy they want, they also know what can make them distressed. So we have to listen to our parents and families. It's really important to use communication and visual aids wherever it is appropriate. So just in nutshell, it will always be around safety and containment, aggression minimization strategies, verbal de-escalation by talking to them in a calm, confident way, not trying to be rough with them, not trying to handle them, using offering them to take some medication which can help them to calm down. But once the agitation is well established, or if the patient is brought quite late, of course we have no choice sorry, but to use restraint, parental sedation, and verbal de-escalation. So this is the kind of pathway which we follow in emergency. So if verbal de-escalation is successful, then we can continue their assessment. But if the patient is not accepting it, or the patient is coming to emergency when the agitation is well established, then we can have to use parental sedation for them, which actually in hospitals we use droperidol or midazolam together, or if third line things which we use are ketamine. If the patient is happy to take oral sedation, nothing like it. Olanzapine wafers are there, which are easily available in most of the emergencies. They are only emergency medications, so nobody should be using them as a script. on long-term ongoing basis, except for the without psychiatrist input. This is not recommended because these are core psychotropic drugs. For a weight less than 40 kg, we often use wafer of 2.5 and 5, which easily melts, but it still takes half an hour and 40 minutes to work properly. So you can't use these if the patient is beyond your control and is just running around. So these are not for those patients, but the patients who are happy to take oral medications. So this is what we offer them. There are some injectable medications which again can be used only after psychiatry approval, which include paliperidone. But risperidone, if the patient is already on, we can try a little bit higher dose just to calm them down. And we give them 40 minutes to settle down. If that is not successful, then we again go through the other pathway. So that's how we manage the patients in our emergency department. I will just quickly go through the discussion points. It's really important again to focus what is mental health condition and what is behavioral condition, because there is definitely a clear demarcation, and it's really important to understand the difference between the two. Usually you will find the common themes. The management is also very common. There are need to be awareness about the legalities, which could be that whether they are in with a residential placement, whether they are with foster carers, are there any other factors like domestic violence and other triggers for them, and what kind of follow-ups and links they have in community, because these patients present again and again if they are not appropriately followed up in community and not linked with pediatricians or psychiatrists. So always there is a overlap between mental health and behavioral pediatrics, and sometimes they may coexist. Usually you may see autism, ADHD, ODD, conduct disorders, anxiety, and once they start becoming more mood disorders, then there could be suicidal ideation and self-harm. In that, family history, past history, use of different type of medications and chronic complex conditions, especially alcohol intake during pregnancy, also is becoming very important to consideration in patients who are not responding to any medications, so which we call as fetal alcohol spectrum disorder. So that is a very common cause of aggressive behavior and usually doesn't respond to many medications, and these patients can have learning difficulties as well. So this is the triad. You can see that mental health is at the center of it, but it is impacted by the biological factors, which could be their physical health, the type of disability they have, social. Also is very important. What kind of family circumstances, school, trauma, relationship issues they had, and what kind of interaction they have with their peers, psychological things, which could be how are their coping skills, what are their social skills like, how do they handle uh, trauma and family relationship, what kind of IQ they have, what kind of self-esteem. So there are a lot of interactive factors which we have to consider for a patient with behavior disturbance. And different parts of the brain, of course, are affected in different mental health disorders. So you can say there are mental health disorders which can exist in these patients, and depending on that, you have to take advice from the psychiatrist, and that is really important in certain patients, especially like eating disorders or who are having panic attacks, or major depression with the major suicidal attempts, OCDs, paranoia. Of course, those patients have more mental health flavor. Now, it's very important, to remember that young people between the age of 13 to 18, 20% of them live with a mental health condition. 11% can have a mood disorder. 10% have a behavioral or conduct disorder, and 8% can have anxiety disorder. Behavioral disturbances are much more common in younger children, but as they become teenagers, underlying mental health conditions and coexisting mental health conditions can come up. So, just to summarize, we need to be very much aware of psychosocial stressors, situational crises, trauma, developmental issues, abuse, neglect, what kind of recurring presentations they are showing, how they are engaging with the health services and the service providers. Are they using any substances? Who is going to take the ownership of these patients, whether they belong to pediatricians or mental health people, social workers, or community services, DCJ? What are the strategies we are using for them? What are the medications they are there? What kind of processes, guidelines, and pathways need to exist? Um, we also have to take into account the anxiety of the clinicians involved, the expertise of the clinicians involved in their care. It has to be a collaborative, evidence-based interaction with these children. And of course, sometimes paramedics and police does get involved. Of course, they also need to be aware of the needs of these patients, and there should be some alerts and management plans for frequent presenters. Um, Legalities, if they come under certain sections, we need to know some information about Mental Health Act and what does that mean for that patients, the documentations, scanned protocols. The documentation has to be really thorough, and wherever we are stuck, we need to seek medical legal advice, which can be from child protection services or DCJ or even psychiatry experts. And in terms of the follow-ups, it varies. These patients, once they are treated and discharged from emergency, they need to come back to outpatient pediatricians or mental health clinicians. They need to get allied health psychologists, occupational therapists, social workers, behavioral therapists. They maybe need to be linked with agencies like Headspace, CAMS, or even a child psychiatrist. Sometimes NGOs play a very important role in patients who are with foster carers, so Bernardo's Benevolent Society, Catholic Care, Uniting Care. We must always be aware of associated medical, syndromic, or genetic conditions. For example, patients who have Down syndrome plus aggression, or patients with autism plus aggression, and what type of medications they use. That is also very important. And last but not least, focus has to remain on education about the pathways which exist for these patients in the community to access services. What are the guidelines which can be used? So this information needs to be available to you as primary care providers. Frequent in services about these pathways is also very important. The skill set, expertise, and in terms of wherever we are stuck in terms of diagnostic dilemmas, it has to be a joint effort to find some solutions around that. There needs to be coordination of care, and I can't emphasize more between collaborative efforts which could be multidisciplinary between not only allied health and pediatricians but also with the primary care providers who actually are the frontline workers for these patients and families. There need to be leadership, ownership, accountability, and teamwork. And of course, if there is some incidents, they need to be reported in hospital systems so that we can actually be more productive and systems can improve to help in the care of these patients. Communication needs to be effective, which could be interpersonal, interagency, um, closed loop communication, effective. Both verbal and written communication needs to be effective as well. So at the end of this presentation, I have listed some references which could be helpful. So thank you so much. Any questions?
Okay, thank you so much. I'm just having a little look. If anyone's got any questions, please pop them into the chat box or the question box. It looks like you've thoroughly covered that, so there's nothing there at the moment. But like I said, we will also be looking at that towards the end as well. So just changing presenter now. I'd like to introduce and welcome Olivia. And just pop, there we go. Welcome, Olivia.
Hi, everyone. Hi, thank you, Mel. Hi, everyone. Thank you, Dr. Atan. That was an interesting, very informative presentation. Thank you. Hi, everyone. I'm Olivia. I'm a nurse consultant, and I'm the GP liaison for the Child and Adolescent Mental Health Services on the Central Coast. I think I've been in the position for 18 months, and I think I've liaised with a lot of the wonderful GPs on the Central Coast. I hope I have been of assistance somewhere along the line. So what I'd like to just on the back of the amazing presentation from Dr. Rattan, just to let you know about what referral pathways are available on the Central Coast, especially for our most vulnerable population, the 12 and under and the 12 to 18. So I'll start with the over 12, and a lot of you guys know about it. So with the over 12 years of age, there is 3 different pathways for referral. The first one, of course, is through myself. I'm the GP liaison. My mobile number is on the screen, but it's also available on Health Pathways. What happens is usually the GP will call, I'll answer the call and say, look, Olivia, I've got a referral. I'll get a bit of information and I'll ask about what are the concerns of the GP. Are they immediate risk concerns or not? Usually after that, the GP will kindly send me over a referral. I will do a triage. I'll contact the client. I'll do a triage over the phone, whether with the client or with the parent of the client. And usually then we will book an assessment date. Being a community service, we have 2 weeks to see the clients in, and usually that will have to be a category E for the triage. So that's one pathway which is commonly used. A lot of the GPs are aware of me and have liaised with me, and it's working quite good. That's one referral pathway. The other referral pathway, of course, is if the client or the client and the parent don't want to go through the GP, you can always, or they're not ready for a referral, you can always provide them with the 1-800 or the mental health triage line. At the moment, the waiting period is very short, so the maximum the person will wait on the phone will be less than 3 minutes. A trained clinician will answer the call, will take the details, and they will triage the client. They'll find out what are the concerns of the parent, and they will usually ask to talk with the client themselves. We have different triage scales. So community is usually around E or F. Anything above E will usually go to the acute care team. They will triage it. So we'll focus on the category E's. So the mental health clinician on the triage line will do a triage. They will refer it as category E, and it will be sent to us usually overnight in an email. We pick up the referral the following day, and we liaise with the client and we book an assessment date. Usually I tend to liaise with the GP of the clients, even if they've come through the triage line, in case we need to ask for some recent pathology, find out if everything is going all right with them, if there's any underlying conditions from an organic point of view, to rule that out before we go down the mental health pathway. I will always get back to the GP, the referring GP, with an outcome of the assessment and let the GP know if the assessment, if the client has been accepted and offered a support package by CAMHS or not. So there'll always be this open communication between the service and between the GP, just to put your mind at ease. You are the center of care for that client, and it's important that we as a service recognize that and give it its due respect, and always come back to you and let you know, okay, this is what's happening and this is what's going on with your client. With the over 12, the third pathway for referral, of course, is through ED. We tend to say that only if there are serious and immediate risk concerns. As Dr. Rattan kindly said, waiting in ED is a very traumatic experience. Unfortunately, mental health will not be always triaged as category A or B, because they're sitting in the waiting room. If there's a cardiac event, that will take priority. Sometimes clients can wait overnight. Sometimes clients can wait up to 6 or 7 hours. It's quite traumatic and quite upsetting for the client and for the parent, especially if we have some behaviors involved, as Dr. Rattan mentioned. So if you have immediate and serious concerns about the risk and the safety, please advise them to go to ED. Once they're seen in ED and assessed by the mental health registrar, they will have an assessment conducted and we will get the referral overnight. The same process happens. We contact the clients, we hand them over to a team, and then they will be followed up with, if they are suitable for us and meet our criteria. We sometimes, presentations that come through ED don't meet the criteria, is no mental health in it, there is no risk. We will always refer back to the GP or the private allied health care provider or any medical officer, or if the risk is there and they need a CAMS input and support, they will be allocated to a team. Now, for the most important and the most exciting part of our new service is the under 12s, and we know there's a big gap in the market and there is a lack of enough support services for the under 12s. So we just started the under 12 service beginning of 2021. Primary Health Network have kindly helped immensely by upgrading and updating the health pathways. If you go on the health pathways, there is a referral form clearly marked for the under 12s, and Erica will come over after me and explain to you, everyone, how to get onto the health pathways and where to find the forms. If you have an under 12 referral that you believe there is a mental health component, please go on health pathways, find that form, and please complete it. The form is very much, it's simple, it's clear, but it asks for as much information as you can provide for us. It will help us to process that referral and provide the very best service for that client and for the family. If you're unable to access that form on health pathways, there is a number there for CAMS, child and adolescent. Please call the number and we will forward a form to you. Then you can fax the form back to us. It will be picked up immediately by myself. We have a daily intake meeting where myself and the team leader for the under 12s get together and we look at the referrals. Sometimes with GPs, you're unsure, is it mental health, is neurocognitive, is neurodevelopmental, what exactly is happening? So the whole purpose of the intake meeting is to decide, is that referral mental health, is it suitable for CAMS under 12s? The decision is made, we take the referral and we roll with it. If the referral is unsuitable for CAMS, I will always get back to the GP with an alternative pathway. Like say, look, doctor, this is a clear case of a young person with autism or ADHD. This is the pathway you need to follow. Always, as with the over 12s, with the under 12s, I will always get back to you once I've received a referral, confirm that I have received a referral. I will let you know that an assessment date and time has been arranged. I will always get back and let the GP know what the outcome of the assessment was, whether the client met the criteria for CAMS and it would be accepted and offered a support package, or the client will be referred to other services. We usually tend to explain that to the client and the parents. We don't just say you're not suitable for us and send them away. We always provide them with different services that are available in the community and contact details for these services. So we try and keep the service as holistic as possible, even if we don't accept these clients as clients of CAMS. We understand that parents out there sometimes are unaware of what services are available and how to go about it. And usually they find that very helpful. Even if we are unable to offer them support, they find it very helpful that we can offer alternative pathways and alternative services. Thank you, everyone. I'll hand over now to my colleague Erica and Dr. Saf.
Hi, everyone. We're just swapping seats over. So we'll just progress on to the next presentation. So thank you so much, Mina and Olivia, for your wonderful presentations. So I have with me Dr. Jill Sass, who's one of our GP clinical editors on the Central Coast Health Pathways website, and I am the acting Central Coast Health Pathways manager. So welcome to our presentation on Central Coast Health Pathways. So we just want to let you know we've got quite a lot of resources and information available on health pathways that's relevant to this topic. So just a quick overview for people who may not be aware of what Health Pathways is. Health Pathways is an online health information portal for clinicians, predominantly primary care clinicians, to be used at the point of care. It provides a summary of information on how to assess, manage and refer your patients and clients, including to local specialists, allied health, public health services, private. There's a variety of information available, and that's to try to get the patient to the right care at the right time in a timely manner. So up here I've just included the web address and the login details, so the username and the password. Those are available for clinicians only, so social and health professionals, and we'd prefer if you just keep those confidential. We also have patient info, so Central Coast Patient Info, which is a companion website, and that's for the community. So that one is open access, and the web address is there for you there, and that's where you can suggest your clients and community members look for patient information and educational resources. This is what the login page looks like for Central Coast Health Pathways, just so people can visualise. And if you have any issues trying to log in, there's an email address there, cchealthpathways@hneccphn.com.au, and then we will assist you. This is what the homepage looks like once you've logged in. So we've got the new and updated pathways section. So if we've developed newly localised pathways for our region, they'll appear there. If we've done a full review and update on a pathway, that'll be indicated there as well. And then in between our full review cycle, which is a standard 3 years generally, there will be partial updates of smaller changes within that 3-year period when changes need to be made. We've also got the health system news section, which is new information about services or local conferences, education which is available, or local news that we think you need to be aware of. And then we've obviously got the health alerts section as well. Okay, so we've got a team of GP clinical editors. Jill is one of those in our Health Pathways team. And the GP clinical editors work with subject matter experts, so that could be specialists, nurses, allied health, non-government organisation staff, dependent on the topic, to localise clinical pathways for our health system, our local health system, and they get published onto our live website, which is listed there. So some of the pathways that are relevant for this topic include behavioural concerns in children, developmental concerns in children, acutely disturbed young person, anxiety in children and youth, depression in children and youth, OCD in children and youth. We've got an out-of-home care page as well for children and young adults. We've got youth mental health page, a deliberate self-harm pathway, suicidal ideation and intent, psychosis and medication pathways related to psychosis, and a child abuse and neglect page. We've also got a lot of referral information available on Health Pathways. So some of the pages that are relevant to this presentation tonight, we've got child development, mental and behavioural assessment. We've got child and youth mental health assessment, child and family community mental health supports, which is more of those non-government organisations that Mina was mentioning that are available in the community. We have the child and youth psychology and counselling. So on that page we have psychologists, neuropsychologists, mental health accredited OTs, and mental health accredited social workers. We've got the child health community support programs, so that's another one of those more non-government organisations sort of pages, but more general rather than mental health specific NGOs. We have online mental health therapy page. So what are the online sort of cognitive behavioural therapy options that are available in this area? We have the psychiatry assessment page as well. So that has psychiatrists that specialise in child and youth care. The mental health helplines page, scheduling a patient, child protection reporting, and we also have a general directory page for allied health, nursing, pharmacy and dental. That's sort of a quick page to link you to all of the relevant health pathways referral pages related to those clinicians. And Jill has recently been working with subject matter experts in this area. So we have some draft pathways which are close to being finalised, and they will soon be published to the live site. So that includes ADHD in children and youth, and the medication page as well, linking to ADHD, and autism spectrum disorder as well. This is just a screenshot of the Central Coast Patient Info homepage. So if you wanted to suggest that to your clients and families who want to upskill, I guess, and get a bit more information and education on various clinical areas, that's available, and that's what it looks like. And then I just thought I'd include our contact details as well. If you have any information that you'd like to suggest, you can send feedback to us. If you'd like topics to be covered or referral information to be added, we welcome feedback all the time, and we're happy to help you. If you have any difficulties navigating the website, just reach out to us and we're very happy to help you. And I'll just check whether Jill has anything else that she'd like to share.
I think that's a good overall coverage of the relevant pages and referral pathways, and I think the new youth counselling pages look great, the referral pages. They're very up to date with, I think that's easy navigation through them, so that look great. Yeah,
great. Okay. All right, we'll open up to questions. So we'll welcome questions in the chat box, and Mel will read out if we have any questions. So I might just hand back to Mel if we've got any questions coming through.
Thanks, Erica. Yes, we've got a couple. Just a couple of really positive comments on the presentation so far, which is great to see. Are there any translated other information for consumers? I'm presuming that, Emma, you're talking about the health pathways maybe for that? So is there any translated other information for consumers?
Okay, yes. So on the patient info website, where we can, we include there's a little flag symbol on there for Aboriginal and Torres Strait Islander people's resources, so resources that are specifically designed for that community, and also for culturally and linguistically diverse communities as well. There's a little flag icon, a compilation of lots of international flags. So wherever we can, we do try to link to existing resources for those priority populations, and that's available on patient info.
Great, thank you so much. And what if there's any changes in medicines or medications that are prescribed? What happens in those instances? Maybe that's one for you, Olivia.
Sorry, Mel, I didn't get the question.
Oh, sorry. What if there's any changes in the medications that's been prescribed for the children that are referred to you?
Sure. Part of our service and part of the episode of care with any young person is when usually the clinician or the case manager that's working with the client will always liaise with the GP. If there's any medication changes or if there's any review by a psychiatrist, the GP will kept informed, the GP will know about it. And usually sometimes we can even, if you request the doctor, we can forward to you a copy of the psychiatrist's review.
Great. What if you have any questions or concerns about your case for the clinicians? Who do they contact?
Absolutely. Usually as soon as a clinician will have a client allocated to them, first thing they'll do is they will send a letter to the GP. So I'm the case manager or the clinician for that client. So if you have any concerns, this is my name, this is my contact number. But as a GP, again, you're the center of care, you're the primary caregiver for that client. If you happen to see the client and you have any concerns, please, doctor, don't hesitate. Give the service a call. Look, you can even call me. I've had a couple of GPs call me about clients that are current clients of the service and say, look, Olivia, I'm worried about this or that. I'm happy to liaise with the case manager of the client, and I get the case manager to liaise with you. Again, it's about making it easier for you as a GP to be the center of care for that client, to be always engaged and always informed about what is happening from a mental health perspective of that client.
Thank you. Is a mobile number given out to clients?
No, please, no. That mobile number, that is just for GPs and and specialists like pediatricians or psychiatrists, or mainly for health clinicians, please.
Okay, and what if you just want specific advice in regards to medication?
Sure. Sometimes GPs are happy to start a young client on an antidepressant or an anti-anxiety medication, but you just need a little bit of support. The psychiatry helpline is available on Health Pathways. The Primary Health Network kindly enough arranged for that to be up there. It's a very easy access number. You can call, you will get a call back from a psychiatrist, and they can give you the adequate and appropriate advice on the dosage, on the medication use. So there's always that support service as a backup if you need that support from a psychiatrist at the time you're prescribing.
Okay, so that seems to be it. Has anyone else got any questions? I'll just give you a couple more minutes. We're nearly at the end of the session. The timing is absolutely perfect, and I want to thank all the presenters for attending tonight. It's been really informative and a really important topic. So just a reminder too that the presentation will be available on our website, and also that the recording of this session will be coming to our website, Education Library, over the coming days. Okay, so I'd like to thank everyone for attending and good night. So we'll see you soon. Bye.
Thank you.
Thank you.
Bye.